One of the things that I know Dr. Connor worked on very heavily in his career is the long-term impact on the health of nurses and other exposed healthcare workers. We definitely need more longitudinal studies, which are difficult to do. And it's not something that you see every day, where I've talked to chemo nurses who said, hey, I've been in this 20 years, it hasn't bothered me at all. Well, until it does. Therefore, it's so important when we're training incoming nurses, how very important it is to start with these practices early in the career and throughout the career.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS. Today, we're talking with Charlotte Smith, RPH and Senior Regulatory Advisor at Waste Management PharmEcology Services in Milwaukee, Wisconsin, about what nurses and healthcare professionals should know about disposal of hazardous drugs and hazardous waste. As a reminder, you can earn free NCVD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Please note that the information provided in this episode is for general education. Regulations on waste disposal vary by state and institution. Refer to your state laws and institutional guidelines for specifics on how to dispose of these medications in your workplace. Thank you so much for joining us today, Charlotte.
Thank you, Lenise.
This is a very complex and confusing topic to most nurses. Can you briefly define hazardous drugs and hazardous waste and how they are different?
Certainly. A hazardous drug is one which poses a threat to the health of those preparing, administering, and disposing of the drug. We typically think of chemotherapy agents as hazardous drugs. We'll talk more about those definitions in a moment. A hazardous waste is a chemical, some of which are drugs, that EPA has determined is hazardous to the environment. Hazardous waste may be listed waste, which are given actual numbers, or they may be characteristic waste, which meet certain levels of concern, such as ignitability or toxicity. Only a small percentage of drug waste meets the EPA's definition of hazardous waste, including a number of chemotherapy drugs. These must be disposed of in black hazardous waste containers. Many hospitals simplify this process by having all drug waste disposed into black containers. Hazardous drugs are defined by NIOSH, the National Institute for Occupational Safety and Health. NIOSH is responsible for identifying drugs that pose a health risk to healthcare workers. The NIOSH criteria for hazardous drugs are carcinogenicity, teratogenicity, reproductive toxicity, organ toxicity at low doses, and genotoxicity. The last official list published by NIOSH was in 2016. There was a proposed list published in 2020, but the final list has yet to be published. We're all waiting with bated breath. NIOSH did publish procedures for developing the NIOSH list of hazardous drugs in healthcare setting and managing hazardous drug exposure information for healthcare settings in 2023, but we're still waiting for the latest list. Unfortunately, even when finalized, that list will only cover drugs approved through 2015. Some additional hazardous drugs have been listed on the NIOSH website. Long story short, it is always the responsibility of healthcare organizations to examine every drug purchased to see if it meets the definition of a hazardous drug, regardless of any official listing.
There are so many things behind the scenes that we have to worry about in relation to these medications. What are some of the examples of hazardous wastes?
The poster child for hazardous waste is warfarin, which, as you may be aware, is not only appropriate for managing clotting time, but is also available commercially as rat poison. This is an example of how chemicals can serve more than one purpose and why dosage and regulation are so important. In addition to some of the older chemotherapy drugs, such as arsenic trioxide, cyclophosphamide, mitomycin, and melphalan, which are listed hazardous waste, healthcare organizations should be managing all chemotherapy drugs as hazardous waste. The reason for this is that EPA's list of hazardous waste has not been updated since the 1980s. EPA addressed this issue in 2019 with the adoption of its final rule, Management Standards for Hazardous Waste Pharmaceuticals, and amendment to the PO75 listing for nicotine. Without going into too much detail, the The rule made it easier for healthcare facilities to manage their hazardous waste pharmaceuticals without as much administrative regulation.
So essentially, it's giving the own institution their ability to manage them in a more restrictive fashion than what the EPA probably has listed.
Yeah, that's true.
What do oncology nurses need to know about hazardous waste disposal in a healthcare facility?
Well, it's interesting because every facility does things a little bit differently, but normally they have used one of three approaches. The simplest and most expensive is to have all pharmaceutical waste managed as hazardous waste. That means that nurses will be trained to dispose of all drug waste in black hazardous waste containers. These will be picked up by a hazardous waste transporter and taken to a highly regulated hazardous waste incinerator. These containers are shipped on a very precise manifest with cradle-to-grave tracking, and the emissions and ash from the incineration process are highly regulated. The second scenario is that hazardous and non-hazardous pharmaceutical waste is segregated in the pharmacy, where it is easier to identify. But nurses still place all pharmaceutical waste in the black container. The third option is to identify for pharmacy and nursing which drugs are to be placed into the black container as hazardous waste and which can be segregated into a separate non-hazardous waste container, usually blue or white. These are still incinerated, but at a waste-to-energy incinerator or an incinerator permitted to manage non-hazardous pharmaceutical waste. At this stage of our understanding of the risks of drugs in the environment, it's really important to remember that no drug should be disposed in the trash or down the drain. The facilities I've worked with dispose of all bulk chemotherapy as hazardous waste, and bulk is an informal term used to mean not empty. The term bulk chemotherapy refers to any containers which still have drug remaining in them. All empty IVs, vials, etc. should be disposed as trace chemotherapy waste, usually in a yellow plastic container appropriately labeled as such. Trace chemotherapy waste should be incinerated as biomedical waste, although some vendors use a chemical treatment. Trace chemotherapy is not regulated in most states. Speaking of biomedical waste, these are wastes that are potentially infectious and are typically disposed in red Sharps containers, red bags, or the yellow trace chemotherapy containers and bags. These need to be treated by autoclave, microwave, chemical disinfection, or other technology that's proven to destroy bacteria and viruses. That's a whole separate issue from chemical waste, which are in the hazardous waste drug category.
I think one of the things that's interesting, you mentioned the easiest thing would be to have everything disposed of in the black hazardous waste, but I imagine there's probably cost associated with the different levels in how you dispose of each of these as well.
Yeah, very much so. Hazardous waste is the most expensive. And the other issue we're dealing with now is there's a backup at the hazardous waste incineration facilities. So some hospitals are having difficulty getting their black containers picked up for disposal. So, ideally segregation is the most cost effective, but it also requires the most training and the most diligence.
I can very much relate to that. I want to change gears just a little bit and talk about our controlled substances. What should nurses know about wasting our opioids or controlled substances?
Certainly, and that's a big issue because we know there is diversion, even though we prefer not to have to deal with that. Most facilities now use one of the sequestration devices currently on the market, such as Cactus SmartSync or RX Destroyer. These should be placed in either the black or blue or white bin, depending on both the contents and the state in which they are being generated. I mention state because that 2019 EPA rule, which allowed for hazardous waste controlled substances to be managed at non-hazardous incinerators, has not been fully adopted around the country. Unfortunately, 16 states have not yet adopted this rule, which makes management even more confusing for multi-state hospital systems. DEA, the Drug Enforcement Administration, has recently requested a response from providers of the sequestration devices like Cactus and RX Destroyer to determine if they meet DEA's non-retrievability standard. At this time, all devices used for waste-controlled substances in the nursing units must be incinerated to meet DEA's requirements.
Just one more layer.
Yep.
Why is it important for nurses to understand the dangers of drugs being released into the environment through wastewater or through other means?
Some of your listeners may have been around long enough to remember the book Silent Spring by Rachel Carson, in which she eloquently exposed the risks to many species by the widespread use of DDT, an insecticide at that time. More recently, the book Our Stolen Future by Theo Colburn, a pharmacist, Diane Dumanovsky, and John Peterson raise the specter of the effects of endocrine disruption on wildlife and humans. The effects of drugs like diethylstilbestrol or DES, once given during pregnancy on the fetus, impacted the risk of cancer and other untoward effects in the offspring. The book remains a dramatic reminder of the risk of exposure to hazardous chemicals, including drugs. Another excellent reference on this topic is the book Generations at Risk, of which Ted Shetler is one of the 4 authors. They discuss such serious topics as the impact of endocrine disruption on gender identity, intelligence, emotional development, and related issues. The National Institute of Environmental Health Sciences also does research on a variety of endocrine disrupting chemicals, including bisphenol A and phthalates, which can occur in some medical devices, including IV bags. So how does this tie back to drugs in the environment? Many of our very potent drugs are also endocrine disruptors, including obvious examples such as estrogen and testosterone. So release of these drugs through drain disposing of IVs is obviously not protective of the environment and ultimately of human health. Placing drugs in the trash may, first of all, be a potential violation of state and federal regulations, depending on the drug and the location. This practice is also a hazard to environmental services personnel and can also result in children being poisoned. There was a case some time ago of a child dying from handling a used fentanyl patch that was discarded in the trash. When trash is landfilled, it's also possible, depending on the landfill practices, for drugs to enter the leachate, which is eventually routed back into wastewater systems. So it's pretty complex.
Very much so. We would always talk about the fish in the Puget Sound when we were talking about things that were going down the drain, and that very much resonated with a lot of the staff that we worked with. In recent years, we've seen an increase in cancer treatments, some of which are hazardous, being administered in the home setting. What are some of the hazardous waste concerns that should be addressed in the home setting before and during treatment?
You bring up a really good point, and I'll get into the explosion of home care chemo in just a moment. Home care oncology nurses should be specifically trained on providing chemotherapy in the home and provided with appropriate personal protective equipment, as well as a chemo spill kit, chemo sharps container, and black hazardous pharmaceutical waste container should the infusion need to be discontinued. Equally important is education of the patient and family members as to the risks and practices needed to mitigate those risks. I've seen a number of excellent fact sheets that should be provided to patients, whether they're receiving chemotherapy as an inpatient or through outpatient infusion clinics. I had the opportunity to write an article with Dr. Tom Connor, formerly of NIOSH, for Pharmacy Practice News on applying assessment of risk principles to home health care. In checking with several cancer care centers, we found that the amount of chemotherapy home infusions soared during COVID and never returned to pre-COVID levels. For example, Penn Center for Cancer Care Innovation in Philadelphia scaled up from 39 patients in March of 2020 to 310 patients by the end of April that year. You can imagine what the stress that placed on that organization. As part of the research for that article, we explored how to conduct an assessment of risk in the home environment. Let's consider for a moment what an assessment of risk might look like in the home care setting. One of the first steps is to identify the dosage forms involved, whether oral tablets or capsules, creams or ointments, or IVs. Similar to the inpatient environment, closed system transfer devices should also be used when giving an IV infusion. Nurses should be wearing full PPE with closed system transfer devices when starting or administering IVs. But patients and caregivers should also be taught to don chemo gloves at a minimum when assisting with IV infusions, applying creams or ointments, and assisting with tablets or capsules. If the nurse is on site, he or she should be prepared to capture any spills and place the spill kit materials into a black container and remove it when leaving. Patients and caregivers should be instructed as to how to maintain and manage any spills, and a spill kit should always be available on site. Providing a home care checklist for both the nurse and the patient and family is a simple way to keep track of all areas that need to be covered. For example, who in the household may be at most risk from exposure? This list includes infants, the elderly family members, caregivers, pregnant family members, even pets. Is there a secure area to store the drug that cannot be reached by children? Is the route of administration by IV the highest concern, topically a somewhat lower risk, or orally the least risk unless the tablet must be cut in half? Is there a dedicated area where the drug can be prepared that is isolated from any food preparation or accessed by children? Who is administering the drug, and where is administration taking place? Ideally, chairs with hard surfaces or recliners that can be easily cleaned should be used. Is a sharps container available for needles and other paraphernalia? Is the nurse or knowledgeable family member physically present during the infusion? Who's responsible for the patient? Remembering that urine, feces, vomit, and sweat may contain the drug. If there is any drug remaining, is there a pharmaceutical waste container available? Who should be contacted if the pump fails or leaks? You can see there's a whole number of things that need to be addressed. Oncology nurses should also advise patients in the home not to store their tablets or capsules in a typical pill container used to manage daily and weekly medications. The medications should be stored in the original container away from pets or children. If the meds need to be stored in the refrigerator, they should be stored in a well-marked, sealed plastic bag or container clearly labeled as chemotherapy. Patients should be reminded to wash their hands with soap and water for 20 seconds before and after administering their own medication. If their skin is exposed inadvertently, it should also be washed with soap and water. If any chemo gets into their eyes, they must be flushed with water for 10 or 20 minutes, and the healthcare provider should be contacted immediately. Another area of concern is use of the toilet. If possible, the patient should use a dedicated toilet for a length of time as instructed by their healthcare provider due to the potential for contamination by urine or fecal material. The patient should be advised to sit when using the toilet and to close the lid before flushing to reduce aerosolization. A lot to remember in the home.
A lot to remember in the home. And if you think about the fact that we train our nurses and they go through an entire chemo and immunotherapy course, many institutions have skills days and they're required to be checked off on administering these chemotherapy agents and keeping patients and their coworkers safe. Yet we're expecting caregivers and patients to manage these at home. I think that's a very, I don't know what the right word is, but it's something to really think about, transferring what we know into somebody who has not been trained to do this.
Yeah, and then you've got the emotional component that you've got a person in your family who's dealing with cancer. So you've also got that emotional involvement.
Exactly. Thinking about some of the home care aspect of this, what should patients or caregivers do if medication is left over after treatment is discontinued or a patient dies?
Fortunately, there are now a lot of drug take-back kiosks available at many pharmacies and some police stations. There are also mail-back kits that can be purchased at a number of pharmacies. And finally, DEA still offers a biannual take-back day where unused medications can be brought to a designated area in the community for proper disposal. These are typically held in April and September or October, and you can find the site nearest you at www.dea.gov/takebackday, or simply Google DEA Take Back Day online. You'll find a map literally where you can find these. It's also a number of other groups that try to offer these periodically too. So there's definitely ways now, fortunately, to manage these drugs where they can be safely protected from both people and the environment.
That's a really good point. And we will put that reference in our show notes for those of you listening. This has been a really great conversation, Charlotte. I just have a few wrap-up questions that we ask all of our guests. How can healthcare professionals evaluate their hidden, unconscious, or implicit biases about safe handling and hazardous waste?
Yeah, I think what happens, we become so into our routine that what we do on a daily basis, we just kind of go through and do it without always thinking about it. And we can forget that not everyone has the same context of understanding these risks that the medications have to both the environment and the individual exposed to them. And I know it's challenging, put on all the gowns and the gloves and whatnot. It gets in the way of doing their job. It's important to educate each individual potentially exposed to these drugs as if they do not have the understanding that we do. So embedding those consistent safety practices into daily routine is so imperative to ensure safe handling of hazardous drugs and then the proper disposal of hazardous waste pharmaceuticals. And that's kind of a newer piece of this. And people may find that there are different practices when they move from one facility to another. So it is challenging to make sure that they're always following those particular rules and regs at their organization.
Really good point. You've got your federal rules, you've got your state rules, and then you've got your own organizations that you go from place to place. And it's like you have to start all over again when you do that. What are some common misconceptions about hazardous waste disposal and safe handling?
I think it's very easy to say, well, only a little bit won't matter. I'm only disposing of 2 cc's or 5 cc's or whatever it might be down the drain, or probably not for chemo. But the point being that even if it's not chemotherapy, that little bit adds up. And we're definitely seeing it in fish populations where there's been issues. I live in Milwaukee, Wisconsin. We have an excellent Lake Michigan water research program here at the University of Wisconsin-Milwaukee. And they are doing endocrine studies on fish and finding kind of alarming results in some cases. So, we're all in this same ecosystem together. So we want to do everything we can to protect it.
I love the fact that there's research being done on the downstream, literally the downstream effects of this.
Absolutely.
What's something about this topic that's not often discussed, but you wish people knew more about?
One of the things that I know Dr. Connor worked on very heavily in his career is the long-term impact on the health of nurses and other exposed healthcare workers. We definitely need more longitudinal studies, which are difficult to do. And it's not something that you see every day, where I've talked to chemo nurses who said, hey, I've been in this 20 years. It hasn't bothered me at all. Well, until it does. Therefore, it's so important when we're training incoming nurses and, of course, those who have been somewhat on the line, if you want to say, all these years, how very important it is to start with these practices early in the career and throughout the career, because we certainly don't want our healthcare workers to suffer for the good work that they're doing.
To that point, what additional training or education do oncology nurses need to stay current on this topic and keep themselves safe?
Well, your timing is really good, because the 4th edition of the ONS Safe Handling of Hazardous Drugs has just been published, and it has several excellent chapters on these topics we've been discussing. So I think that would be a really easy reference for your members to access and get some really good information.
Are there any other resources that you can think of that would be good for patients or providers who would want to learn more?
Well, when I was researching that article with Dr. Connor, I went to a number of the nationally known cancer centers in the country, and some of them do provide excellent, relevant information on their websites, especially for patients and caregivers. One thing we haven't talked about is sexual health during chemo. That's another issue. All of those are really well done, and most of them, I would say. So I would say even just perusing, doing Google searches on cancer chemotherapy and protecting the patient and the provider.
Thank you so much for this, Charlotte. I think it's been an excellent, eye-opening thing for our listeners to just start to even think about this a little bit more, even if they've been delving deep in this for a lot of their career. You've brought up some really good points. Do you have any final comments for us?
Well, I really appreciate the opportunity to discuss these important environmental and personal safety issues with ONS members. It's been kind of a crusade of mine for the last 20 years to help healthcare organizations manage drug waste better. It's not a real sexy topic for most pharmacists, but it's been important to me because I think that protecting our environment and therefore ourselves is an extremely important part of managing our healthcare systems. Thank you so much for the opportunity.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.